That is so wonderful, so moving, and thank you. We're going to wrap up a little bit with the last presentation. I'm going to be sharing with you some of the results of our center for the COM procedure. I'll have to apologize in advance. We're still gathering a lot of data, so this is not very complete in terms of extent of the data that I'll be showing you. But just to give you a little bit of a glimpse of how we're doing in terms of the numbers so far. My disclosures here are not particularly pertinent to this presentation. So just to give you a bit of background, and you already have heard some of this, but this was the COM procedure was first applied in 1993 in Brazil by Dr. Da Silva. And then this truly over the years has proven to be the only true repair. You can, next, okay. Since 2005, when he first presented at the ATS the video showing the rest of the world how to do this, and this really became embraced by the surgical community gradually. And after all this extensive experience that he had had in Brazil, and through which he actually taught many people all over the world, and in collaboration with other experts, as we heard earlier today, we then were able to recruit Dr. Da Silva in 2016 to Pittsburgh, and Dr. Mora created the Da Silva Anomaly Center. So we've had our own experience here in Pittsburgh, some of which you already heard. It's that the battery is not going so well. Okay. So since then, the Silvas have performed here in Pittsburgh 110 procedures. So I'm going to cover a little bit of the postoperative complications that we've seen, the mortality, some of the adverse effects, and just very little on the valve function. Just to tell you about the population that we've seen in Pittsburgh, you can see that there is a small number of infants. There were 9 infants in this time period. Most of the patients that we've served are children, there's almost 30% actually were adults, as you heard the moving story earlier today. So this really reflects the diverse age presentation of this disease, and truly how when you're dealing with this condition, you have to be ready to tackle from the fetus to the adult with congenital heart disease. A significant number of these patients had prior surgeries of some kind. As you can see, 38% had tricuspid valve repair or cone performed previously at other institutions. We had 8 stars, as you heard now that number has gone up. Isolated BT shunts or PDA stents were present in 10% of the patients. Some patients had bidirectional Glenn, and as you saw an example earlier, there were 2 patients that had a prior tricuspid valve prosthesis that underwent cone after tricuspid valve prosthesis. Most of these patients were symptomatic, although you heard before also how difficult it can be sometimes assessing symptoms, and that often you do need exercise data or other parameters that actually demonstrate limitations. And some patients were very, very sick, as you can see, 5.8% extremis in ECMO. Preoperative conduction abnormalities were quite common in over half of those patients, but about 7% of them had WPW. Of all these patients that came for a COM procedure, all of them had a COM procedure, and there were no initial tricuspid valve replacements. This is the median cardiopulmonary bypass time and the cross-clamp time. And it's very common that at the time of the cone, these patients have additional concomitant procedures, which may be a partial or complete closure of the atrial septal defect, CTI ablation or MACE procedure, sometimes pulmonary valve or after tract procedures like reconstructing the pulmonary valve, or pre-existing takedown of very surgical shunts. Obviously, that may be necessary. You can see that with the growth of our program, we have had a significant increase in the number of patients referred for these procedures over the last few years. And these patients have come from all over the world. You can see that it has become one of the most common resources for referrals, outside referrals to our program, is Ebstein's anomaly, which is incredible considering the rarity of the condition. When you look at the distribution in age groups, as a little bit was said before, but also shows you how infants are rare, but they still happen. So every year we have a few infants that give us trouble, give us headaches, because those are the most challenging. And obviously we're all learning on how to manage them, and there were very nice discussions on that early on. A little bit on the early postoperative events. This gives you the mean length of stay was 8 days. The ICU stay was 3 days, so very reasonable. Need for reoperation early, tricuspid valve repair in one patient. One patient needed a shunt because of decreased pulmonary blood flow, and one patient needed a Glenn. Temporary ECMO was used in 4 patients, and there were 4 patients that needed a pacemaker. Some of the late events that we have collected so far, and obviously so important as most of the bigger numbers we've had in the last couple of years, we really look forward to seeing this data over time. But we have had tricuspid valve reintervention in 4 patients, 3 of whom had a redo. So this is 2.7%, so redo of a cone. There was 1 patient that required a tricuspid valve replacement, an adult patient. 1 patient who had presented late and had severe ventricular dysfunction, an adult patient, ended up referred for transplant evaluation and ended up having a transplantation. There were 2 patients that needed a Glenn or a Starnes, 1 each, and 1 patient ended up having a Glenn takedown. 1 patient required a pulmonary valve replacement. And there were 2 non-cardiac deaths, so essentially no mortality during this follow-up, which are recognized as relatively short for the most recent patients. But there was 1 patient who had a brain tumor, a glioma, and died after that, after having had neurological surgery, and another patient who died from who had a tracheostomy, who died from a respiratory complication related to a tracheostomy that had nothing to do with the heart, really. So probably if you do a statistical analysis, we may find that brain tumor is a predictor for death after, if you have after the cone. In any case, when we look at the tricuspid valve regurgitation, you can see that the vast majority of patients, over 80%, had a moderate or severe degree of tricuspid valve regurgitation. And in the last echocardiogram, that shifted significantly towards the trivial or mild, with much less residual insufficiency after repair. We are gathering a lot of these data now, so we're hopeful that in the next year or 2, we could especially present to you MRI data and echo data, and hopefully some exercise data in the older patients that can help us understand, the timing of this condition, of this surgery, what are the best times to do it, and the implications. As has been presented before, this is especially in infants and neonates, the mortality is quite high all over the world. This is data from STS, and this was shown previously too by Dr. Arnold Craig. So it's really, I think we're very proud of the incredible team with the Da Silvas here and the ICU care and the multidisciplinary efforts to take care of these patients and have such good results, especially when incredibly pretty much absent mortality in this group. So just briefly then, just to conclude, we can say that of these 110 patients that included very diverse complex populations, including patients who had had Starnes, patients who had had prior cones in other institutions, prior failed tricuspid valve replacements. These patients all were able to offer a cone repair with remarkable outcomes, with no mortalities and relatively minimal morbidities. So this is really life-changing for these families. It's clearly showing a durable longitudinally function, and also really enhances how much we really need to study these patients. I'm hopeful that we can put together an international registry for Ebstein's anomaly so that we can really gather information, especially about the timing of intervention. Now that we have such a wonderful surgical technique, should this be done much earlier before we're seeing all the late effects of right ventricular dysfunction, arrhythmias, etc., to really improve outcomes, quality of life, and impact this patient population further with benefits. So I think this is a challenge for all of us, and hopefully we can be proactive about gathering that information and getting our patients involved in prospective ongoing surveillance. Thank you for your attention. I'm just going to say that this has been wonderful today. I don't know if there are any questions for me. I know there wasn't any particular panel after this, and we had a chance to talk a lot. There's my email, and I can also we can also connect through the online for any questions that may come up. I wanted to thank everybody as we're wrapping up, and especially, this has been an incredible journey, as you have seen some of the pictures that you saw before. I want to thank especially for this symposium today, all the faculty and all their wonderful presentations, especially our invited guests, Dr. Noel Craig, Dr. Simone Pedra, and Dr. Norm Silverman, of course, for incredible contributions. And I wanted to thank the organizers, especially Katie Scollon and Drew Berghardt, for all the work to put all the details together, our patients that have contributed, and we couldn't do any of these without Jim Ferris with Massive Media for all the audiovisual. He's done always does an amazing job. It's the supporting work from HVI and from Children's Hospital of Pittsburgh to allow us to do all this, present this here today. And of course, the course directors, and especially Dr. Jose Pedro da Silva and Luciana da Fonseca da Silva and Dr. Morel for putting together this symposium. This has been really wonderful, and we hope to keep doing this every year and give you some more further updates as we learn more about this very, very challenging condition. Wanted to make a little announcement about the patient-parent conference. That's something we're going to push for next time. We're going to try to gather a larger group of parents, and there will be an announcement for a future event in the spring, especially dedicated for parents and patients. So for those parents and patients that may have logged on, we will have more to come, okay? Thank you very much.